Good evening and welcome back. Most of the discussion around India's public health infrastructure in the past year has been centered on fighting COVID-19. But amidst this big challenge, India has taken an important step towards better delivery of healthcare by committing itself to build its digital highways through the National Digital Health Mission. If NDM works, the familiar scenes of hospital waiting rooms with patients carrying binders of their medical records for the doctor's reference could soon be a history. Our third and the final panel will discuss about reimagining public health via the digital route. To moderate this session, we have with us Dr. Garima Singh, who is the founder and CEO of Axia Healthcare. Dr. Garima founded the Health Assist in 2021, a startup which follows a hybrid model to provide a complete ecosystem to take care of non-urgent and urgent medical needs of the patients. She has been a healthcare professional with over 22 years of experience in corporate healthcare of India, with an experience that covers the entire gamut of healthcare delivery. Our panel today comprises Dr. Ajay Kumar, Executive Chairman, Healthcare Global Enterprises Limited, Mr. Rajiv Sikka, who is the CIO, Medanta, Mr. Rajiv Shivan, who is the Group Head Projects, Asia Healthcare Holdings, and Shraddha Somani, who is the Director, Key Accounts Manager, Lead Square. Thank you, and may I request all the panel members to come on board.
Good evening, ladies and gentlemen. Thank you very much. We've had a nice tea break and back again. So this is a very interesting panel, which is on reimagining public health via the digital route. We have an eclectic panel, very eminent panelists. So may I start by requesting the panelists to please introduce themselves, and then we deep dive into the questions, which will be taken up by the panel. So starting with Dr. Ajay Kumar, if you could please introduce yourself to the audience over here, please.
I'm Dr. Ajay Kumar. I'm Executive Chairman of Healthcare Global Enterprise.
That's a very short introduction to a very long and lengthy profile that he holds. He is the chairman and the executive director for HCG Group, which is known to have completely revamped how we look at cancer care and how cancer care is now made accessible across the country. So, and more we'll get to know him through the panel. So we now move to Shraddha.
Sure. So I'm with Lead Squared, trying to support their initiative of enabling the healthcare institutions to reach the consumers better. In short, I'm taking care of their expansion and retention business in the healthcare industry.
Perfect. So we will be talking about technology aspects, the CRM aspects, and how we can utilize it in the healthcare arena in revamping it. Mr. Rajiv Sikka.
Hi. I'm part of Medanta IT, with them for roughly 7.5 years, but before joining healthcare, I was a pure tech service provider into BFSI and other space, so new experience and new learning in the healthcare. Look forward for this discussion.
Thank you very much. Mr. Rajesh Sivan.
Hi, I'm Rajesh. I head projects for Asia Healthcare Holdings. This is a single specialty healthcare platform of the private equity TPG Capital, and we run single specialty chains across the country.
Thank you so much to the panelists. As the audience can see, we have a panel which actually covers the entire gamut of what is required for us to reimagine healthcare. So where exactly are we is the first question that we have to establish. So if you see in the last decade per se, just to put a context to it, we have made literally leaps and bounds of progress in healthcare on the public health side. So we have increased our life expectancy from 64 years to about 68 years. Our infant mortality rate has gotten better. Certain public health initiatives, Swachh Bharat initiative, open defecation has been reduced from 65% to 20%. As a also, we are polio-free since 2014. So these are big leaps that we have taken. Having said that, the challenge that we currently face across the country is with regards to accessibility of healthcare and the quality of healthcare. We still rank 154th out of 195 nations in the accessibility and quality of healthcare. With this as a foundation, may I now ask Dr. Ajay Kumar to please talk about his experience about what are the gaps in public health and what are the ways that we can look at plugging those gaps.
In my journey of nearly 45 years, both in US and India, we find that healthcare is segmentized. When you look at India, there is the affluent India, middle class India, where they look at really convenience, awareness. Today, I can say categorically in India, when it comes to healthcare, what we see in 300 million population or so in big cities, we are on par with the Western world. There is no question. The accessibility is there. In fact, we may have more beds than what we really require. And there is a lot of talk about healthcare, but what we need to really use the digital or other platform. Today digital is the buzzword, but really think about convenience for them and also awareness about it. So access to information, not fake information, but real information. Today, one of the problems we also find is there's so many information which is coming out. What is true and what is not, it also becomes a major issue. How do you dissect what is really the right information from not so? How do you get that kind of information? So I believe as we go forward, I'm talking about this section, we are looking at really the data. For example, when you have hospitals, like I'm being in cancer care, the most important factor when a patient walks into the hospital, am I going to the right hospital where I'm getting the right outcome, treatment and outcome? Hardly anybody today publishes the outcomes. So we have to really look at using the digital platforms, data collection. One of the things we are doing and we are advocating for all hospitals is to really back it with authentic data, well-curated, independently done data. So that way a patient knows they're going to right. Because, we all feel, oh, this is a great hospital, this is a great place, we can access, we can do, but is it really so? So that is where I think we can make a big difference. Now coming to big cities, technology is there. And one of the things, even in tier 2, tier 3, like what we have done, we have made hub and spoke model, we have made it accessible. But technology is definitely there in India. And even the cost-wise, if you all know, in health, cost compared to US, where I was there for nearly 28 years practice, is 1/10 the cost. If, for example, if you do a PET scan in India, recently I had a friend had a PET scan in US, near Chicago, the cost was $2,500. We do it here for $300. So the entire same equipment, everything is there, but there may be HR related cost difference and all. But overall, India has mastered in terms of really cost differentiation and providing it. Whether the cost can be afforded or not is a different story. And in the big cities, mostly it is met either through insurance or pay out of pocket. That can be discussed later on as we go. But when we go to the other section of the population, what we talk about, the 900 million or so, that is where I think the public health is an issue. For a long time it has been an issue because accessibility has not been there, and also awareness. So that is where, in the past we have struggled, whether it is for cancer care, cardiac care, or whatever the nutrition. We know sometimes we hear that we have done work with World Bank where reproductive age, rural women, anemia, below sub-Saharan region. So there is a wide gap in India. On one hand, you are an advanced country almost. On the other hand, you are sub-Saharan region. That is the problem. That is the challenge for us as healthcare providers, how to do. And here we have to really look at what is the government role. Why is government really playing the right role? How digital locking and all the systems are coming now. How can they make this accessible for the other populations, rural, who are economically weaker? Through this, can they get into more preventive? Can they get into better awareness? And most important, get the right treatment at the right time through this awareness and have their medical records, which we are talking about. So it becomes accessible. And not only that, in future, there could be, like a team, could be a multidisciplinary clinic advice. So through the technology, smartphones, we can access that. So that can make a huge difference. I think that is where we are headed. India has a chance to leapfrog using this kind of technology. And we have already done the telephysics, teleradiology. In fact, I'm happy to say digital pathology. We are far ahead of the advanced country in these areas. We are already far ahead.
True.
In fact, they are looking at it. And of course, what we lack is publications, research publication. The reason we are not in the top of the world, we are damn good doctors, damn good treatment. We are, honestly, we feel when we go to US, a lot of doctors, patients go, all Indian doctors. So we are brilliant. But in India, why are we not become number one in the world? Because we don't collect data. Absolutely. We don't publish. What comes in New England Journal becomes, say, viral, whereas we don't publish because we have we have clinical capabilities, good outcomes, but we are not publishing. But using proper data, digitally, curating, if we publish it, I am sure we could be the leading in healthcare industry in the world today. We can. So this is where the gaps are, and this is possible solutions.
Fantastic. Thank you so much, Doctor. Going to Mr. Rajiv Sikka. So essentially, world is becoming smaller and smaller because of technology being available. Almost every industry has adopted technology for a wider reach, faster reach, greater reach. In this regard, what do you have to say when it comes to healthcare adopting technology to making it more accessible, more affordable, reaching it to the right people at the right time?
Sure. So, I'm not going to talk about in a tertiary care hospital because that's very easy to handle and manage. And there are multiple examples. Even in the morning, people talked about, care being at the bedside. So we have been using an EMR application, which is a handheld device, and it's 100% adoption. So, but let's move to the public healthcare. And I'll give 3 examples, and these 3 examples are in production in real-time use in Medanta. So no theory. We run India's largest CSR, which is called TB Free Haryana. It started with TB Free Haryana, now it runs in 5 states where we have hospitals in the state of UP, MP, Jharkhand, and now Bihar. What we do is that TB has more mortalities compared to any other disease in the communicable world. And what happened was that when we carry a big bus or a van, we go to a small village or district where roughly between 180 to 220 odd people generally gather. And there is a radiologist, there is an X-ray machine. Now what happens is that we all know that X-ray is a very cost-effective, less invasive, easy to capture, but at the same time, getting it, report means that we have to have a radiologist who have to read the report and figure it out. And not just in India, but worldwide, the ratio between radiologist and patient is very, very low, and India is no different. Now what's happening is that we implemented a AI-based solution by which as soon as the X-ray comes from the modality, film comes from the modality, report also comes. Earlier, the radiologist was using, roughly 4 to 6 hours before each report can be seen. And all these 200 odd people, most of them are daily wages laborers. They are ignorant people. They won't stick around for 6 hours for the report to come, and they simply vanish. And you have nothing to catch hold of them. The addresses are also very pathetically mapped in the records. So what's happening is now, we have roughly 40 odd cases which are coming out, which are probable, TB. Because what we want to do is that before declaring it as a TB, we want to doubly sure. So radiologists, instead of looking into 200 odd X-rays, is looking into 40. And that's how we are managing the show. And this is like a fantastic success, helping us to move these programs in multiple places. Because honestly speaking, we were not able to make it. Radiologists was a shortage. So this is one example. Second example, during COVID, everybody, was fully afraid of going to a hospital, while few of us were coming on a daily basis, and fear was very justifiable because we were the hub of COVID. At one time, out of 1,250 odd bed, roughly 900 beds were devoted to COVID patients because that was the scene in Medanta, Gurgaon. So a lot of people who were supposed to come after either PTCA or CABG, which means after, here I don't have to explain, everybody's a doctor. PTC is a stunt and CABG is bypass. I'm just revising it for myself. So, yeah. So we have to have an ECG done. So in this particular case, patients were not willing to come to the hospital and the neighborhood clinics where they earlier used to go to a cardiologist were not open. So what we implemented is a 6-lead ECG device, which is like a pen drive equivalent. It's FDA approved. Within 30 to 40 seconds, you do it, ECG will come to Medanta Heart Command Center, and there is a cardiologist, minimum consultant level cardiologist sitting 24/7, and that ECG is read. It has only 3 call to actions. Don't worry, everything is okay. We see some trouble, but you don't have to be panic. Come tomorrow morning, we'll book an appointment with the cardiologist, which means then OPD consult has to be carried out. Third is that, it's a serious rush to any place, be it Medanta or anywhere you have. So this is one, and we did thousands and thousands of ECG using this tech, and now, as our flabo goes in the morning for a blood sample, a lot of people are getting this ECG done through this device. Now this device, a lot of patients are taking it at home, which are not nearby, in the nearby cities. They take it home and they run it for 3 months, and after that we get it collected. Each and every ECG which is done by them comes to Medanta Heart Command Center, which is read by a cardiologist. So these two trends, if you look into this, morning we were talking about care away from the hospital, and I'll touch upon this topic since you talk about tech. Third, which is a very beautiful example, and I love this. I'm a hardcore programmer. My roots are in the programming. I've done programming throughout my life. When COVID protocol policy came somewhere in June by the government that asymptomatic patient or less symptomatic patient can be treated at home. This was Saturday afternoon. We were sitting with the district civil officers, and we were not aware what it means. How do you treat patients away from the hospital, and that to COVID patient. So suddenly we decided, there is a protocol. Within 48 hours, we were up with a live site in which we were enrolling patients. Patients were feeding their important vitals directly, or people who were not able to do that, a nurse was calling them, and triaging was happening using the system itself, which means that if you have a threshold which is below or above a certain parameter, which is the subjectivity of the doctor, intimation goes to the doctor pick up the call, and a video consult was done immediately then and there itself. And that way, again, we treated tens and thousands of patients. It was not a sexy tech. It was a simple web page, data entry secured, OTP driven, and triaging. And in case something goes wrong, ambulance was there, which used to pick up the patient and bring them to the hospital. We reserved certain number of beds for those kind of patients who were getting treated. We call it the home care package for COVID. Had it been not the case, which is tech, I think no other country in the world also was able to care to, so many patients which were overwhelming for the hospitals, and Medanta or most of the hospitals in India were no different. And again, this is third example, which I thought that we were able to reach out to someone which was outside the hospital, and according to me, these are the initial founding or small steps for public healthcare future, which is definitely going to get driven by tech. See, when you talk about volumes, scale, tech has to come into picture. Otherwise, it's not possible.
Right.
That's my view.
Thank you so much, Rajiv. So public health essentially is about prevention of diseases and promoting good health. And both of which somehow neither the government is able to push forward nor the private sector. So now we have HCG and Medanta represented here, and both very eminent onto the private healthcare delivery space. So this question is to Dr. Ajay Kumar, and then we'll move to Rajiv too. How is it that these organizations can make a foray into the community and ensure that there is a seamlessness once we are able to train and teach about health promotion, early detection, then the treatment? How is it that it can be seamless and there is no rich, poor, diversity which impacts the outcomes for us?
I think that is the challenge, for us to penetrate the communities. If you go back to look at cancer care, the belief in early 2000 was cancer care, you have to come to big centers, big cities, because A, it's a long-term care, B, the technology, the expertise is not there.
Right.
But today I'm very happy to say that even in tier 2 and tier 3 cities, phenomenal cancer care is available. Not only technology, but the issue for us was, like you said, seamless, is how do we make a proper diagnosis? How do you do pathological interpretation? How do you do the physics for radiation? How do you do radiology interpretation? But in the last, I would say 10 to 15 years, even before COVID, everybody talks about COVID, technology, COVID has changed. But all of us were doing even before COVID. We had multidisciplinary clinics, tumor boards, and the most important thing is what we are doing was, by centralized physics, centralized radiology, centralized pathology, we don't need expertise in all the places.
Correct.
The concept in the past was, we need technology in the smaller cities to do proper treatment. In India, it was all cobalt in early 2090s. Yes. And we were one of the first to say whether they can afford or not. We took the view, whether it is poor or rich, cancer doesn't know. Cancer requires the right treatment the first time. By giving treatments with cobalt and saying we are poor country, we should do cobalt, we were actually causing more harm to the patient by treating normal tissue. So when we pioneered and got rid and showed that it can be viable through this centralized system, a lot of people followed, which is very good. Today, more linear accelerators, more good therapy is there. But penetrating this market initially was the challenge. And including pathology. You can't have, pathological diagnosis is very important. And if you make a wrong diagnosis, patient gets the wrong treatment. If you don't stage properly, patient gets. That is why cancer got a bad name. Because everybody said, okay, patients are coming in late stage, treatment, it recurs, maybe treatment is worse than disease. All these kind of misconceptions were there. So what we did was change it very clearly to say that we will do equal treatment even if it is Ranchi or Angol or Vijayawada or Nasik or Bangalore or Delhi. So that concept even now is not sunk in. Now people always think they have to migrate, but they don't have to.
Correct.
And technology is going forward. The amazing thing what we have done recently is the mixed reality, which is very cost effective. Suppose we have a patient in, let us say, Angol or Ranchi, who requires a team effort, who requires major surgery. Normally they would have come to Delhi, Bombay, Bangalore or somewhere with their family. The cost, the ability to come is not there for everyone. Even if they come, the cost they incur, stay there. Now the avatar of our doctor can go there, which we did recently, and performed a big surgery. The doctor was assisting sitting in Bangalore, head and neck surgeon. So this is a game changer.
Absolutely.
In my view. With this, we wearing a halo lens, it is cost effective. Mixed reality is there today. It is not future. We all saw it in Star Wars movies. Early, in the 90s and all, we saw how it was done. Today, it's a reality.
True.
Our doctors stood there, actually marked on the patient. From your marked.
Right.
And the pencil mark was there. And how to, even radiation we can do. And radiology, of course, has always been there. So future is very bright. And the other important thing what we need to do is really to make it seamless to do is the data collection. Because people just cannot go any disease and get treatment not knowing what is the outcome of that place. Every place, through digitization, technology, collecting data, should help to bring uniform care across. I trained in MD Anderson, which is one of the premier oncology centers. Today we can say, we did a study to show our Bangalore center compared to MD Anderson as equal or better outcome in breast cancer. Like that can even Angol have, some Ranchi have. Wherever they get treated, how do we bring uniformity? So outcome measures.
Right.
And even a doctor who performs surgery, how can a doctor do one major head and neck surgery once in 6 months and say, I am an expert? So when we collect the data, we say Dr. X did so many surgeries, post-operative death was so much, the recurrence rate was so much, so he should not be doing this surgery unless he has more expertise. A Dr. B has done 10 surgeries, his post-operative death is 0. So what we aim in our institution is 48 hours, 72 hours post-op death should be 0. When they say 5% is accepted, we do 5% for that 5 patients, it is 100%. So whatever happens, did you do pre-op screening? Did you use immunoscoring? All of that are very important before the patient goes to the OT table. So this is where even families get somewhat, as a doctor I'm speaking hoodwinked, when the doctor says, oh, we expect a mortality of 5 or 10%. Not acceptable. It is not. We have to prepare today technology, anesthesia. In the past, the problem was time bound. I have to do surgery in half an hour because anesthesia. But today, anesthesia can be given for 12 hours, 16 hours. So there is limitless, and we have, bloodless surgeries. We have technology so that instruments which can do, stop the bleeding right away. So with all the technology, there is no need for this kind of post-operative. There's nothing acceptable post-operative death. There is nothing. Even in cancer care, when patients recur, first thing the doctors, as an oncologist, I'm telling is, let me start the second line. But can we do data banking? Can we know why this patient recurred? What is the story behind the story before we go to second line? That makes a huge difference. In oncology today, 48% of the patients get unnecessary treatment. They're not getting the right treatment. So can we create A, B, C, D? Based on that, can we give right treatment? This is the challenge for the future. When we do genomics, when we look at all that. So in order to make it seamless, to go to entire population, whether it is cardiology, oncology, doesn't matter, it has to be data bank, it has technology, has to be there, and availability of a specialist. Today, no longer one doctor can give an advice in a complicated situation, whether it is renal, cardiac, or oncology. It has to be multidisciplinary. So we can't expect 5 doctors to be there away. So with a smartphone, using my phone, I can bring in 5 doctors right away. Doctor so-and-so, it is the film here. This is the X-ray. This is the pathology. What do you think as a molecular diagnostic radiologist? What do you think as a medical oncologist, as a cardiologist? What do you think we should do for this patient? Patient is also there.
Absolutely.
So we give advice in 10 minutes. What used to take weeks together, and some patient wouldn't have even survived. Today we do it in 5 minutes. Today, I have a patient who was flown in from Oman by private jet in Bangalore. 5 minutes we put together a team, started aggressive treatment, and day by day his patient is getting better, which was unthinkable years ago. So I think it is becoming seamless, but how do we penetrate entire country, right, which is the challenge. It can be done. It has to be done, last word on this, it has to be done in a focused factory approach. We cannot dilute ourselves. It has to be experts who are focused factory. I can't say I am a pizza maker, I am also a dosa maker, I am a dokla maker, I make everything in the multi. It cannot be experts in this. So when you go to a restaurant, you have all this, it's an average restaurant. So today we need expertise and sub-expertise in that, where technology plays an important role.
Right. So Rajiv, in this current environment where we have, let's say, resource constraints, the brain power is limited, as Dr. rightly pointed out, right? Very good specialists are limited in number. Even average specialists are very limited in number, as we are fully aware. Doctor to population ratio in India is really not good. Neither the patient to nurse ratio is good, right? So you need to have technology to get into the community and to ensure that the outcomes, as Dr. pointed out, are reported, acknowledged, and surveillance around it happens. So my question again is, with regards to, let's say, your organization, what efforts are being made to push healthcare into the community and not to push community into hospitals?
So, this is again a learning which we got during COVID. We started running camps in RWAs in Gurgaon. Now we have permanent nursing unit, which is 24/7 in 30 plus RWAs of Gurgaon. That's we call it as a communities services. Obviously, this is we are for profit, so these are paid RWAs clinic, where there is, first of all, it is always manned. Manned is the wrong word. There is always a nurse 24/7 there. Doctors visit there for each 2 hours. Based on, and then on demand, you have either a physiotherapist going there or a nurse going to service any of the geriatric patient, which is on demand, which means that you have to go to the app, ask for a service. It's a prepaid service, which means that it's a mandatory prepayment, flavo at home, medicine at home. And what we are doing is that based on some respectable volume 5-7, a super specialist is going into that clinic once in a week. And what we do is that, like we used to run camps, we run camp here, which are not purely related to clinical side, but also on the holistic side, which means that, you know, there will be a nutritionist going there on how to cook good food from, you know, from one of the diet educators of Vedanta, or a yoga instructor, which is part of our holistic wellness. He goes there on, you know, one of the Sunday mornings. So what we are doing is that way each community on an average, or each RW on an average, has between 1,500 to 2,000 odd residents which are habitant there. So multiply by 30. So we realize that only way, see, no hospital have that kind of a capacity by which they can accommodate all the population of India, as sir rightly said, that we don't have that capacity. So, you know, best way is to have preventive healthcare. Best way is to ensure that people go for regular tests and other stuff. And mostly what we see for in the near future is that care away from the hospital, and preventive and holistic healthcare is going to play an important role. And that's where the most focus is going to be there. Not just
so
by
Rajiv,
us, but others.
If I may, what percentage of the traffic did you see move from like offline consultations, let's say, to online during the COVID period? Because everybody understands that COVID acted as a cultural accelerant, right? Everything, the way that people viewed healthcare, how people accessed healthcare changed. So what was your experience over there?
Sure, okay. My favorite topic, I can write a book on the subject. During COVID, our volume of telemedicine consults went 12 times. But, you know, numbers is not important. Let's understand the trend. There are 4 myths which I want to break it here. We were of the opinion that it a young people phenomena because it's an app, it's a tech. More than 50% of the people who were coming during telemedicines were 55 and above. Okay. Second myth was that it's a city phenomena. More than 40% of the patients who were coming on the telemedicine app during COVID were either from UP, Bihar, and Jharkhand. You know, and traditionally these states are not known for early adoption or tech-savvy states. Third was that serious patient in any case has to come to the hospital because they have no other alternative. We realized that 40% of the patients were coming of either cardio, neuro, or what was the third one? Some third one, which was again a serious one. Onco. Okay. So these are the 3 set of specialties which were contributing more than 40% of the patient. Fourth was that only old patient will go to telemedicine platform because they are captive, they have no other options. Again, we realized that more than 35% patients which were coming to Medanta were purely new patients. They have never been part of Medanta before that. So what's happening is that, according to me, we are not still at the same peak, definitely, but we have constantly and sustainably maintaining 6 times of our pre-COVID telemedicine consults. Simple reason, you don't have to come one more time to show your report. You don't have to come for a typical chronic care diabetic patient, don't have to come. In telemedicine also we have 3 modes. 1, video, 2, telephone, 3, chat. Correct. And commercials are different. So a lot of diabetic patients just share their insulin and sugar rating in a chat, and doctor has to just say that continue with this medicine, change insulin level to this, job done.
Perfect. So I think what we take back, and this is particularly for the audience, because what we have to understand is that we assume that the rural areas do not have the modality to pay, or we think that they're not aware enough to seek help. Problem that is actually existing is the cultural divide, which does not allow them, to move from the comfortable zone of the village and town to get into the cities. But because of the digital medium, they feel pretty comfortable accessing the medical help So this is one big thing which, COVID has changed, and we've personally experienced it. I think all the doctors and the administrators have experienced it. And I think it's a step in the right direction for that. Moving to Rajesh, now digitalization has actually made healthcare asset light. We are all aware of it. So the kind of money that we would spend, let's say, if we were going and setting up a clinic in a town, or even in an RWA, vis-a-vis now just having a telemedicine setup, wherein, the person sits in front, the doctor is sitting wherever he is, and his time is also optimally utilized, whether it's an offline or an online consultation, and he can directly consult with the patient, prescribe, and the prescription is available with the patient right there, right? So what are your views? How can we optimally utilize infrastructure with this digital change, which is making healthcare asset light?
You're right, Garima. The last 2 years has taught us a lot of things, So just for a brief, we run single specialty chains. We used to hold a company called American Oncology initially, and then we have something called as a mother, which is a single specialty mother and child space. We have a Nova Fertility, which is a fertility chain space we have. This is pan-India. So what we have seen as a trend, in fact, COVID has definitely taught all of us to be, how to gear up for such an event. Like Rajiv just pointed out that a lot of consulting has gone online. We in fact saw that 100% of that went online in these 2 years. Because what happened is, especially in the mother and child space, this is a younger generation population, younger population. They have hands-on, they are hands-on on the gadget. So we saw more and more of them only getting onto online. They would prefer that rather than walking into the hospital. What we used, and the percentage initially was, say, about, before pre-COVID was about 10-15%, which moved totally 100% in the last 2 years. And surprisingly, that trend now continues. Even after the hospitals have opened up, traffic is back to normal, people have started moving, we have seen that the online consulting is what they still prefer. And we still advocate that. Now, how that has impacted in infrastructure? Two things. We set up about 3-4 hospitals during those 2 years. I mean, we had acquired an asset and we had to complete it because of the rentals and stuff like that. So we went ahead and built those centers. We had committed to a certain size of the asset. But later on, which is 2021 onwards, we have invested in about 4 more assets now, which is less by 25% of the space. 3-4 big things. Like we, in the mother and child space, we run the largest NICU setup in South. Like in city of Bangalore, we have got about 6 hospitals. In the city of Bangalore, we have about 100 NICU beds. Okay. Babies come all the way away from about 200 kilometers, 150, 200, 300 kilometers. We started an ENICU. We're going that route. Because reaching out to, getting babies on time or, getting a good pediatrician to support a baby 300 kilometers away was becoming difficult. So we set up an ENICU, which shortly is coming up in this part of the country also. So that is one learning. So what that does is that reduces a lot of load down from the hospital asset. Right. And what big thing that we saw is, see, none of us want to go to a hospital, right? And we have our own, fear of going there, number one, because we have a fear of unknown. We have issues related to parking when we go there. We have to stand in long queues. Initially, we used to have, we never knew when our chance would come. We have to stand for the food. We have a chance to stand for the pharmacy, everywhere. So what has happened is with these online consulting and a lot of other these, electronic stuff, we started cutting down on spaces a bit. We saw a reduction of, as I said, 20-25%. On the capex front, initially we used to spend about, say, 5% of our cost on IT capex. Like earlier, I think Gautam had mentioned in his speak that was the least thing we always used to do. Right. Yes, I agree. As investors, we always kept that in the back burner. It used to be 5% of the project cost. Now, I think that has gone up to almost 10-12%, the IT cost. Now, where that has come out from is not from the medical equipment or anything. It has come out from the regular infrastructure cost by way of, reducing space or by way of thing. without compromising, of course, the patient safety and stuff like that.
Right.
So yes, to answer to the question, it has directly impacted the asset. We have gone down to smaller hospitals now. A mother and child hospital, which used to be 50,000 square feet earlier when we acquired, is now somewhere about 35,000 to 40,000 square feet. And that actually, you know, and what happens is, when you do such smaller ones, your running costs are lower because it has some tangible effect.
Right.
So that's where it is.
Fantastic. So I think one of the biggest, like has been pointed out by Rajesh, advantage of digitization and you know, the introduction of digital health part is with regards to reduced costs and making it asset light. If it is asset light, the investors tend to invest, so more centers are coming up, more accessibility, more affordability. So this is the chain which we are following, and hopefully that trend continues, you know, in the coming few years. Moving to Shraddha. Shraddha, with regards to, you know, Lead Squared particularly, now when we're talking about seamlessness when it comes to customers, patients, right? So how is it that you engage, or your organization engages in making it, you know, somewhat more accessible, somewhat more approachable for the organizations and their patients?
Sure, Garima. I'll just pick it up from where Dr. Rajay Kumar was mentioning about tier 2, tier 3 cities, right? You know, unfortunately, currently the situation of India is that any preventive healthcare measures look like a myth, because the better health indicator today is a geo code than the genetic code, right? And in order to do so, I think the 4 challenges that we keep talking about: awareness, accessibility, absence of the right healthcare facilities, and affordability, right? As Lead Squared, we are enabling the healthcare institutions. And when I say that, I do not just mean hospitals, because it's an entire ecosystem of healthcare that has to come together and work in a digital manner in order to reach, you know, in order to reach what will be called as an ABHA number. Right, so now the ministry is assigning an ABHA number to any child which is born, and at Lead Squared we, you know, we name that as LEAD. So what I'll say is that any child who's born is a lead generated in the nation. And we take the journey of this lead whole through to the entire ecosystem, which involves pharmacies, diagnostics, hospitals, laboratories and medical equipment providers, you know, and several suppliers in the middle of the chain, right? As Lead Squared, we are aiming to give a 360-degree engagement for these patients. We are looking at, number 1, awareness, helping a lot of diagnostic chains today in order to do targeted communications to, you know, to the patients in order to help them understand about you know, making a choice, because awareness is one thing and making a right choice to actually get a healthcare, especially in tier 3, tier 4 city, is a different ball game altogether. So a lot of diagnostic chains are today, you know, enabling this culture. A lot of health tech organizations are using Lead Squared in order to enable or enhance the culture of making that choice of maybe taking a test beforehand than actually reaching a chronic stage. The second measure is accessibility. Now, you know, I will include the absence and accessibility together, right? Because as you rightly said, sir, that the doctors are not always present, right? The specialists have to be really, you know, segmented in order to reach the consumer in the right time and accurately. So in order to do so, Lead Squared is, you know, helping a lot of hospitals today to onboard the doctors on their telemedicine applications, on their hospital infrastructure as well, in order to communicate with the consumers directly, reach the consumers at the doorstep, be it tier 3, tier 4, or tier 2 cities. Another thing that we're also noticing it, you know, I was talking to a tech vendor a few days ago, and they're using drones in order to supply the medicines. Now, if we talk about Himalayas, a small 8-kilometer distance might take a lot of time if you have to supply a medicine to, you know, to a consumer or a patient. Now, if these medical providers are using a CRM, a medical CRM like Lead Squared, they are able to automate the process so quickly and maybe onboard the drone and, you know, supply these medicines within a span of a few minutes. And that's changing the accessibility. and absence of doctors, obviously, as we are all making an attempt to onboard the doctors, or, the ministry is also taking impactful initiatives like EHR, the health registry, to onboard doctors. There's also a need of, pharmacies around the corners of India. And, our features like geotagging, geofencing, or mobile application in the hands of all the field sales executives of such pharmaceutical companies is enabling this part. So now they can actually, the field sales executive can stand at a location, can look for the pharmacies around, and if there are no pharmacies, this is also enabling the ministries or the suppliers to open a pharmacy there, or maybe to enhance increase the supply of a medicine if it is in shortfall. Let's say, if regions of UP are facing high cases or high volume of cases in HIV, or in Bhopal, if we are seeing a lot of cases related to thyroid, right? That deserves a huge attention or huge demand of certain medicines like this. And Lead Squared is enabling the medical suppliers also to, to provide or enable the access to medicines. The fourth point, which is affordability. Now, it's very funny that, ministries are supplying a lot of, are inputting a lot of money into the system in order to help people afford these medicines, etc. Where Lead Squared sees an impact is twofold. Number one is, within the hospital ecosystem, we are trying to reduce the costs by automating the, automating all your processes, starting from, let's say, the call center used case, where we are automating your call center teams to onboard a patient, to actually not just engage with them, but also to begin with, attract them, acquire them, engage them, and then retain them, right? So we are doing a lot of work in order to reduce those costs, make them efficient, in terms of increasing the productivity of the salespeople or the medical reps or the billing department or the finance department, etc. Integrating with the EHRs in order to reduce time taken to action on anything, right? Or integrating with all the diagnostic labs who have done a test of a patient, and when the patient actually comes in, he has his reports, already supplied to the hospital. So this entire cost effectiveness that we are bringing across to the hospitals is going to reduce the cost being suffered by the patient as a ripple effect. So that's one way that we are trying to touch the affordability part. The second part is a lot of insurtech, insurance companies are currently joining hands with the lending companies as well as the hospitals in order to make the healthcare cashless. Now, in rural areas, obviously, they do not have insurances. They don't understand the importance of it, right? And these insurtech companies, as a digital transformation measure, they're trying to penetrate deeper into these segments, right? Now, that requires a deeper integration with hospital like yours also. And which is where Lead Squared is enabling this entire ecosystem to help the affordability measure, on not just tier 1 level, but tier 2, tier 3 level as well. So to cut it short, I think what we are doing is we are making the consumers make a right choice of saving their lives and enabling the healthcare institutions to seamlessly touch that consumer at every touch point.
Perfect. So I guess from a seamlessness perspective, it's critical. The role is critical for us to be availing this service to ensure both the customer and the delivery partner is kind of bridged. So thanks very much for that, Shraddha. So Dr. Ajay Kumar, this question is for you. Much like food and water is a very basic need which every Indian should have, similarly, availability of health is a very basic need. Now, we are fully aware that the government, like I said, in the past decade has made a lot of changes. There is Jan Aushadhi Kendra for pharmacy dispensing, generics and all. You've got Ayushman Bharat. Yet it is only tailor-made for tackling, if I can say, an acute issue, and truly not moving in the direction of preventing and controlling the NCDs, the non-communicable diseases. So what, in your opinion, should the government now be focused on? What are the 2-3 things that we, from this medium can communicate back to the government to say, okay, this is where we need to focus, and these are the few things which will work out?
Yeah, you know, like I said before, this is a challenge for everyone. We have done a lot of studies on this, particularly when we have a disease like oncology, dealing with it. But I always take a complex situation and try to simplify. You know, when you look at other countries, like what United States spends nearly $9,000 per person, healthcare. You look at Europe, 5,000 plus, India, $83. So there is a huge gap. But that doesn't mean it is not doable. Brazil has now covered entire population. So where is the problem in India is lack of understanding on the part of the government what really needs for healthcare. I'm very sorry to say schemes like Ayushman are really popular to get votes. But really, do they do the thing they're supposed to do and connect? They don't. In fact, in our study, Ayushman patients, 44% increased mortality because it doesn't cover for everything. But government, public media and all talk it's a great program, but it is not at all a good program. If you look at the Harvard study which was done for us, and if you look at some of the Porter and others who done a lot of work, I normally don't like to quote abroad, but they think it is a terrible program, honestly. Because it is half-baked.
Yes.
Patients are getting false hope. Imagine a patient who comes to you, I have Ayushman card, I'm going to get all the cancer care. And imagine reality, they're getting only 40% of the care, 20% of the care. And they think they go home and the cancer comes back. It is terrible for the patient and their families. Misinformation, under-treating, not covering. So what is the answer to this? Answer is rather simple, universal health care. Now we have migrated with technology. We know what is the cost, how we can monitor outcome. The least the government can do is monitor this. Ayushman Bharat, what is outcome to cash paying patients? And patients going to good centers, what is it? They will have the answer there. Answer is right there. But people don't want to go because it is frightening. Look at prevention. We are radical. We think, we know tobacco, what causes. 40% of cardiac, including cardiac cancer, respiratory, can be eliminated by banning tobacco. Simple stroke of a pen. Why don't they do? Because it is related to revenue and other matters. Can we provide alternate for this? When you talk about poor people, what they chew, smoke, if just you make it non-available, health will improve in India tremendously, cost will come down. Simple solution, not willing to do. But blame people, doctors cost are high, that is high and all. That is the problem, yeah.
Yes.
Problem is, if you take away tobacco, we are into alternate farming. 50 farmers we have developed in tobacco belt of Karnataka, which is one of the 3 important belts in this country. By alternate farming, we have just recently had a press meet on May 31st to show that all the farmers said their income has actually increased compared to tobacco. And they gave a vivid description of what was happening to their hands, face, respiration, working with tobacco leaves. So this is simple, but common sense is so uncommon. We don't want to do. Because there are other vested interests.
Right.
It is high time government becomes transparent, understands this from people who are involved in it day to day. The decision makers are bureaucrats, not technocrats. One day you are in metro, tomorrow you are in healthcare secretary and teaching us about health. This is what happened. Teaching us what is health. A guy who was a metro coming to healthcare. True. So these kind of issues are not talked by public because we want to be nice to the government. We want to say good things. And nowadays, we are also afraid whether we'll get an IT raid or something if we talk. And these are the problems. One day I was on Z talking. I got a call from government saying, you should not talk against the government. If there any problem, talk. We are creating a society which now becoming accepting whatever happens. Discussing, debating in the interest of the public is what we are. Why did we become doctors? Essentially, we become doctors to help the community health care. And when there is tobacco which can be eliminated and healthcare, why not be in the forefront and do it? Right. And we should as doctors. lives. As healthcare professionals, we should become very forceful in this.
Right.
Because, when we see an advanced case of head and neck, recently I saw a lady last week in my tumor board, advanced tongue cancer. Advanced means she can't even swallow, big tumor sitting. All from tobacco chewing. And passive smoking. Nobody talks about passive smoking. So this can be eliminated by single stroke.
Right.
We can all go and do some other work, take up. But this is where I think technology, in a way, you can interrelate because we can get hard data. Today, what we should focus on healthcare, when we talk about preventive health and others, what we do, cardiac. How many people know obesity is the #1 cause of cancer? How many people know, cardiac smoking is also related to cardiac diseases? So we have to make a concerted efforts, and we are taken up this cause. We have made it public. We are to alternate farming. We want to go after the government. We filed a case in the government, in the court about tobacco. But again, it is dragged on for years. How you know what it is? But I think unless we become proactive, we are all reactive. A disease comes, we want to treat. If we become proactive, there is an answer to rural healthcare. Rural healthcare is lifestyle, preventive, and longevity can happen if we take some of these fundamental measures. And that is why we are at crossroad. Cost, we talk about cost. We can talk, by reducing this, cost is also eliminated.
Absolutely.
Cost will be like healthy lifestyle. So we need to look at this, monitoring this, and data should be in the forefront.
Absolutely. So I think surveillance, if you're talking about public health, without surveillance and the data being analyzed, data being published for public consumption, as of now, data is there. It is held, like Dr. Jayakumar said, with certain bureaucrats, not widely shared because there are vested interests. So this is one part of the problem. The second part is we truly do not have an effective lobbying for public health issues. There are distinct areas, geographic areas, wherein cancer incidence of a particular kind is on the high. Everybody knows it. But what initiatives are taken in that area? That's a big question mark. Neither do we as a population ask, nor are we told. We might have the anti-tobacco, advertisement coming up in the movies, but the kind of people who go there are the ones who are usually, they have good access to cancer care. But what about the interiors wherein there's chewing of tobacco and all? So I think it's a very valid point. It truly reflects the current scenario of public health, the apathy which is there, not just in the government, I would say as a population, we don't demand it. So maybe advocacy and lobbying does have a...
Yeah, actually, like Dr. Ajay just mentioned, taking this preventive health into the rural we are rightly poised. The government is sitting on a huge database. With the last 2 years of whatever has happened, we are sitting on a huge database, which is a good opportunity to right now go there and get to the roots. Because 80% of our country is the hinterland. All good hospitals or the private network is in the rest 20%.
Right.
Why do people come from there to these cities? It's because they don't have it. They either don't know it. So one is awareness, and then talent. Get the talent there, get the quality there. I'm sure this can penetrate.
Fantastic. I think I totally agree with the panel over here on this.
Just a small point. I think the benchmark indicators is something that might not be in hands of ministry, but you guys. And as you rightly said, you are sitting on so much database, right? And if there are preventive measures, a heart attack, if it's measured, and spare me for my limited healthcare, knowledge in terms of medical, but if there are 3-4 parameters, which could be indicative of a cardiac arrest coming, to any patient, I think those sort of awareness programs or campaigns, could be made available, as soon as a patient gets a pharmacist's test done. And if the report is positive, it should lead you to speak with that patient immediately. It should lead your call center team to take an action and reach out to that consumer. Right? Because right now the only source of truth that we have is Google, which makes us feel like we will die anyhow in a week's time if we even have a headache. So, some serious benchmarks is something that I think could be drawn through AI ML mechanism, sitting on top of a CRM system and integrated EHR system that could enable this thing.
One point I want to add is, we talk about rural people, lack of awareness. In the past, we have to make camps, physically go, talk. Today, with technology, webinars, smartphones, we can access not just hundreds, but millions of people, which was unthinkable even a few years ago.
Right.
We should use that technology to create awareness, like we call about skill training.
Yes.
You know, we are involved in skill training, rural, to bring them up to industry standard. Same way, how do we bring rural people to the urban standard without them moving to this village to urban? We can today. So just use this, whether government does, private enterprise. Ideal thing is the government outsource. In my view, government cannot be regulatory and also performing functions. It's high time government decides what is my role. You know, and starting hospitals and saying I'll also regulate is nonsense. You know, starting schools I'll regulate should go away. Government should be either regulatory and cutting information. Yes, here is a patient, you guys treat, give him the same outcome as a guy comes to private, pays cash. I will monitor. I will pay you for that. That is simple as that. That is where per patient what government spends in government hospitals is by one survey is more than what private hospitals spend per patient. Absolutely. So government is actually spending more because of the bureaucracy, infrastructure, all the things. So it's high time. Now education we are slowly taking in urban at least, in rural it is not. Right. So there is mammoth job for government to, if you want to become an advanced country, there's no way at this stage we can unless we take these measures.
Absolutely. So I think the big point that we take back is regulation, which in this country, even in the previous session when we were talking about, you know, the quality of air conditioning in tier 2, tier 3, wherein there is no positive pressure, negative pressure. There's just one uniform, you know, flow of air across, whether it's an OT or a ward area, right? Now, there has to be some basic expectation when somebody is setting up an organization, which is a healthcare delivery organization. This is where the government needs to step in. This is where, you know, from an awareness perspective and quality of delivery of care perspective, the government needs to step in. So I guess we've taken down quite a few points. We'll have probably another 10 minutes for question and answer sessions, if time permits. I'm not very sure of the time, though. Yeah, so we'll take a few questions and we'll wrap it up with a summary. Yes, please. The question.
Well, interesting discussions on the reimagination of public health has happened. But when a kind of extreme view is expressed that preventive health care has not been dented. In fact, that practically ignores the health policy of the government and the huge investment that transformation of healthcare has been made in India. Besides, when everybody talks of national, PMJY scheme and the schemes which provide hospital-based care, most of the discussions forget that the major component of the transformation of healthcare was health and wellness centers. Now, what was health and wellness centers? This is exactly the core issue, reimagining the public health through the digital route. Today in the country, 118,000 health and wellness centers are functioning. They have 30 parameters monitored on a digital frame. Every community health officer, mark my word, community health officer, which was non-existent, and this CHO is 6 months full-time trained person, qualified nurse, now stationed in a population of 5,000, which was earlier the sub-center, and she is functioning, a qualified nurse functioning for 5,000 population, focused on only preventive and promotive care. Did it happen in the last 75 years? It didn't happen. This has happened in spite of the pandemic. And these very CHOs and the so-called A&M, the ASHAs, they have delivered the care. If this would not have been so, pandemic would not have been under control. Deaths would have been 10 times. The vaccination of 1,94,000 has happened through this framework. If this is not preventive health, this is not public health, then what is public health? The investment that India made in vaccine production development, research, and actual delivery on the ground. Who funded it? It's the people's money delivered through the public health system in this country, not by the private sector. Delivered through community-based healthcare functioning system that delivered the care. So it's a myth that Indian, I'd say, governance system did not perform. It did perform, and it's strengthening every day. So when we say reimagining public healthcare, absolutely, India is on a very strong footing. If that would not be so, the World Health Assembly, 75th World Health Assembly in Geneva, recently recognized the path-breaking work of ASHAs in our country. They are the unsung heroes, and they are actually handling the tablets, and they are feeding the data not only on childbirths, they are feeding the data on growth of the babies which are born. They are feeding on nutrition.
Sure.
And this is digital transformation which is happening.
Right.
So one view is there, but we need to have a holistic view of the entire landscape. Thank you so much.
So just to add a point, we all agree that in the past decade, India has definitely, like we started off by saying how the health indices have improved. But the fact also remains that we are 154 out of 195 in the country, ranking when it comes to quality and accessibility to healthcare. So yes, we've done a lot. Probably we should have done it much earlier. So that is the baseline we are saying. Having said this, the good work which is being done is not being negated at all. What can we do more? How can we leverage technology and digital medium to enhance awareness, enhance accessibility, enhance affordability? I guess we have focused on that. And I think, Dr. Ajay, would you like to add to something, or any other panelists?
I just want to add, there is no question we are doing. The question is, when you spend a very insignificant part of the GDP on health, and when you say, the gentleman said public money, not private, it is only private money, it is the taxpayers' money. Please understand, they don't print money public, it is a taxpayers' money. We all pay, one of the highest taxpayers. But the question is, I can have a day-long debate, it is being properly utilized or not. When PSUs are spending and wasting money, Air India and all, why can't it go to public health? Can they do whatever they want? See, the issue is much broader. There is no question ASHA are doing good job, but when you look at a report from WHO and others, some of the India is still sub-Saharan. Recent report has come, which is published, Lancet, everywhere. So we have problem. We cannot say we don't have problem. We may be on the right road. We may be on the improvement, but can we fast track it? Can we do? The discussion here is, for the future, can we bring rural India to on par with the urban India? That is the discussion. Not that they're not doing job, but we need to have a vision. We need to spend more money per capita to bring us on par in health and education. No country can become advanced country without health and education. Health is a fundamental right, some people say. We have to spend. We have to make it come up to the par. But we are doing things. There is no question. But can we do more? How we speed track, leapfrog technology today? That is the discussion.
Absolutely. I hope that addresses. Your point is also well taken. The progress is well acknowledged, but we have a long way to go. I think that's the bottom line of the session today. Any other questions? Yes, please.
More of an observation, really. I think Dr. Ajay Kumar said that you can't progress without having investments in healthcare and education. One of the observations I have, we very often say government isn't doing this, private sector should do more. I feel healthcare is also an individual responsibility. It's not a right that falls from the heavens, right? So nobody expects the government to take care of your life insurance. You are expected to be aware enough to understand what you need to do for life insurance. Similarly, you need to understand what you need to do to ensure your health. And to ensure that health, to understand that, you need education. So the two are linked. So it's just a broad observation, not specific to anything that's so specific, but that's my view on the matter. Thanks.
Agree. So awareness is, digital medium has actually impacted the most, because if you see during COVID times, the kind of information and good information which is coming was through, your mobile phones, to say that, if this happens, this is where you need to go, these are the helpline numbers, this is where you can get, oxygen from, or this is your nearest center, right? So technology does help. Awareness can be, fast-tracked by using the digital medium. accessibility also can be now made because the doctors are available to you on your mobile. So you don't have to travel. So leave alone the cost of travel. The burden which used to be there on the infrastructure in hospitals, like Rajesh said, that 25% less space is now required in hospitals. Why? Because you used to plan more services for the attendants, not for the patients. A lot of space used to go into catering to the attendants. Now you don't need to do that, right? You can have just the right kind of patient coming in, and only staying the right amount of time, and then discharge back for out-of-hospital care. All of this because of the digital medium now. Yeah. Rajesh, you want to say something? Okay.
Yeah,
Great.
I have one question here.
Yeah, where?
Back
Okay,
of the room.
sorry.
So when we're talking about public health and digital route, we also have a great legacy of Ayurveda and other healing practices. And lifestyle, like you said, sir, it's extremely important how we approach with our previous knowledge about healing human beings, merging with digital and data and evidence-based medicine to get a better community health created.
That's for Dr. Jayakumar, I guess. Integrated holistic care.
Question on Ayurveda. Now we see phenomenal. Ayurveda is phenomenal, plant-based. If you look at one of the most potent drugs in oncology, taxane, came from yew trees, which is in sub-Himalayan. We didn't know. When some Westerner was traveling, he asked a woman, she said her tumor in the abdomen went away when they put the leaf on her tummy, and that is how taxane was extracted and became synthetic. Billions and billions of dollars were made. It was in our own backyard. So what the lesson from that is, it is like we go look around all over the world for something what is in your own backyard. So it is high time we spend enough money to really research in Ayurveda. What the problem is, we are not able to find the active ingredient, enough time and look at it so that that active ingredient could be propagated and given at the right time. We all have anecdotal cases where Ayurveda worked, lifestyle, people do it. Definitely it has a positive effect. We think it's complementary. A lot of times yoga, Ayurveda, everything. But can it be the only treatment? Can it be more prevention? Yes. But can it be the only treatment for a lot of diseases? We don't know that because we have not done enough R&D work on it. We need to do that work. And honestly, I think if we do, there is amazing. There is a group in Bangalore, Dr. Darshan, who has collected thousands of Ayurveda antidotes. He is trying to do like that. We need to do because we have that kind of knowledge in the past, but we need today in the scientific world, the data, we need to establish that. That is where I think a lot of work can be done, and it will be phenomenal. It will be path-breaking. But we are become followers of the West. Even research, we don't do research. Medical research is almost zero because somebody is doing. Look at pharma industry in India. I'm sorry to say, we are copycats. When is the new drug we do? We don't spend money. When you talk to the pharma, quarter to quarter reporting, I can't spend money for research. If we don't do, how can we be leaders in the world? That is where we are facing the problem. Zero research, but great pharma generic drugs. We are #1 in the world because we know how to copycat. But we are not originals. That is the problem.
Very right.
We have to understand problem first and then come to... Smart copycats. Smart body shoppers and call smart copycats. We are very good. We are extraordinary. We have brains. We run Google, we run Microsoft, we run IBM. Phenomenal. Indian doctors are phenomenal. But why is it not happening? We have to analyze. True. And then come to... That is where we need government, private, everybody come together, think tank. We need to analyze. We need to put scientists, innovators together. Correct. A nation has to form a policy based on that. True. Not bureaucrats making a decision. That is where the issue is.
Right, well put. So I guess to sum up the session today, we would say that, eventually public health is all about trust. How many of us can actually access a public health facility for our own needs? Till the time we are not able to do that and we seek out, private healthcare, that means there is an issue that we have to address as a country. Thank you very much.